Hey everyone, welcome back to Drug Detectives YouTube channel. My name is Dr. Boznak, and today we're diving into some Naplex questions that'll have us thinking like the pharmacy superheroes we are. So grab your notepads and let's jump right into the fun. Alright folks, first up we have a 45-year-old woman with type 2 diabetes. She's been on metformin, but her A1C is still sitting pretty at 9%. What's our next best step here? Let's check out the choices. Option A, increase metformin dosage. Sure, metformin is our first-line agent for type 2 diabetes, but if the A1C is still high, simply increasing the dose might not be enough. It's like cranking up the volume on a radio with poor reception, just doesn't improve the sound quality much. Plus, higher doses can lead to gastrointestinal side effects like diarrhea and nausea. We want to keep our patient comfortable, right? Option B, add glipizide. Now we're talking. Glipizide is a sulfonylurea that works by stimulating the pancreas to release more insulin. This is especially useful for patients who are still producing some insulin but need that extra push. Think of it like giving your pancreas a little pep talk. However, we must keep in mind the risk of hypoglycemia and weight gain with sulfonylureas. So regular monitoring is essential. Option C, start insulin therapy. Insulin is a powerful option and can definitely bring down A1C levels, but it's usually reserved for patients who are not achieving their targets with oral medications or in cases of significant hyperglycemia. Starting insulin therapy also requires additional patient education and monitoring to avoid complications like hypoglycemia, so it's a big step that we want to take carefully. Option D, recommend a low-carb diet. While lifestyle modifications, including dietary changes, are crucial in managing diabetes, a diet alone won't bring down the A1C level fast enough. It's like trying to fix a leaky roof with just a bucket. You need more comprehensive solutions. But hey, we definitely want to encourage our patient to adopt a healthier lifestyle alongside medication. So the best answer is B, add glipizide. This combination will help get that A1C down and keep our patient feeling good. What is the take-home message? When managing diabetes, remember, if the A1C is high and your first line is metformin, think about adding a second agent. It's like saying two heads are better than one, or in this case, two meds are better than one. Moving on to our next question. We've got a 32-year-old male with community-acquired pneumonia, CAP, and a penicillin allergy. What's the best antibiotic to prescribe? Check out these options. Option A, amoxicillin. Amoxicillin is a great option for treating many infections, but it's a penicillin derivative. Since our patient has a penicillin allergy, prescribing this would be a serious no-no. We definitely don't want to send him to the ER for an allergic reaction, so this is off the table. Option B, azithromycin. Now we're talking. Azithromycin, a macrolide, is a fantastic choice for CAP, especially for healthy patients without significant comorbidities. It covers the typical pathogens like Streptococcus pneumoniae and has good atypical coverage too. Plus, it's well tolerated and has a convenient dosing schedule, usually just once a day. It's like your trusty sidekick, always ready to step in when needed. Option C, ceftriaxone. Ceftriaxone is a cephalosporin and is a good choice for more serious infections. However, it's important to remember that cephalosporins can cross-react with penicillins in some patients. In this case, it's best to avoid it due to our patient's allergy. Safety first. Option D, levofloxacin. Levofloxacin is a fluoroquinolone that can effectively treat CAPI, especially in patients with more complex medical issues. However, it's often reserved for cases where patients are at high risk for resistant organisms or have failed previous treatments. It's a powerful option, but let's not jump to it unless necessary. So, the clear winner here is B, azithromycin. It's effective, safe, and perfect for our patient's condition. What is the take-home message? Remember, folks, when dealing with allergies, especially penicillin, always choose antibiotics wisely. Macrolides are often the go-to for CAP. Just think, allergy alert, go macrolide. And now for our final question. Here it is. A 20-year-old female with asthma is waking up frequently at night and using her albuterol inhaler more than twice a week. What's the most appropriate next step in her management? Okay, this one's pretty important. Let's unpack it. Option A, continue current therapy. Continuing her current therapy when she's experiencing nighttime symptoms is a recipe for disaster. This approach essentially ignores the fact that her asthma is not well controlled. We're not trying to wait for things to get worse before taking action. Option B, add a LABA. Adding a LABA can be effective for patients whose asthma isn't well controlled on just a bronchodilator. However, LABAs should always be used in conjunction with an inhaled corticosteroid to ensure safety and efficacy. You wouldn't send a knight into battle without his armor, right? Option C, increase albuterol usage. Oh no, that's a red flag. Increasing albuterol is a dangerous slippery slope. Over-reliance on rescue inhalers indicates poor asthma control and can lead to more severe issues. We don't want our patient to be the poster child for overusing her inhaler. Option D, start a daily inhaled corticosteroid. Bingo, this is the best choice. Inhaled corticosteroids are the cornerstone of asthma management, and starting one will help reduce inflammation, prevent those pesky nighttime awakenings, and allow our patient to breathe easier during the day. So, the answer here is D, start a daily inhaled corticosteroid. What is the take-home message? When asthma symptoms creep in at night, it's time to step up therapy with inhaled corticosteroids. Think of it as giving your lungs a daily hug. Remember, nighttime symptoms, corticosteroid solutions. Now that we've tackled those questions, let's take a moment to reflect on some key topics frequently tested on the NAPLEX. First up, diabetes management is a hot topic. You're going to see questions about medication choices, lifestyle changes, and understanding A1C goals. Remember, the trend is shifting towards combination therapy, especially when patients are struggling with their targets. Next, infectious diseases are always in the mix. Be prepared for questions on antibiotic selection, particularly around resistance patterns and allergies. Familiarize yourself with common pathogens and the most effective treatments. They love to throw curveballs. Lastly, let's not forget respiratory conditions like asthma and COPD. You should be comfortable with different classes of medications, their mechanisms of action, and when to escalate treatment. A solid grasp of asthma management guidelines can save you here. Let's learn some fun mnemonics to make your studying easier. Here are a few mnemonics. For diabetes medications, Mighty, Glycemic, Champions, Metformin, Glipizide, and the insulin trio. For asthma, Asthma's Friendly, Pharmacist, Albuterol, Fluticasone, and Salmeterol. Remember, NAPLEX isn't just about memorizing facts. It's about understanding concepts and applying them to real-world scenarios. Keep your head up, stay motivated, and approach every study session with a sense of fun. You've got this. Thanks for tuning in to the Drug Detectives YouTube channel. Until next time, keep learning, keep growing, and always put your patients first. Happy studying!